Hello and welcome everyone. Today's presentation is on IABP, the Intra Aortic Balloon Pump. Coming first to the history of the IABP. In the 1950s, the diastolic augmentation discovery was done by the Kankowitz brothers, who discovered that the perfusing the coronary arteries with the systolic blood pressure during the diastole increases the coronary blood flow in dogs. So, as you can see here, they introduced the concept of diastolic augmentation to improve the coronary blood flow. So, in this, by augmenting the arterial pressure during the diastole, one could effectively increase the coronary blood flow. Now, they did a study by a length of rubber tubing to delay the arrival of the peak arterial pressure wave in the coronary artery during the diastole. Now, this is the systole, this is the diastole, the white. During the diastole, by augmentation of the aortic pressures, we can improve the perfusion in the coronary arteries. This is the coronary blood flow, which is primarily during the diastolic period, and by increasing this perfusion, we are improving the perfusion of the coronary arteries during the diastolic period. This was the basic concept of first thinking about a diastolic augmentation. This increase in the coronary blood flow during the diastole is thought to improve the outcome of the patients in myocardial infarctions. Now, going back, in the 1960s, what we got were the auxiliary ventricles. These were the first mechanically circulatory support devices which were actually used in humans. This was in early 60s. In the late 60s, the prototype IABP was demonstrated and it showed benefits of the diastolic inflation and the systolic deflation and altering the blood flow dynamics. In the 70s, this was clinically used and multiple studies were done with mixed results, some showing improved survival. Thus, IABP gained recognition as an hemodynamic device which improves outcomes in cardiogenic shock and cardiac procedures. Now, it continued to evolve. Modern catheters and percutaneous techniques were introduced in the 1980s, thereby expanding the utility of IABP in clinical usage. However, coming to 2023, a lot has changed and major trials have not definitely shown any improvements neither in terms of morbidity or mortality in IABP. So there rages a debate about whether we should be using this device or not. So next important thing is the balloon. Now the technical aspects regarding the balloon is the IABP comes in various sizes, lengths and volumes. The fully expanded balloon should not exceed the 90% of the aortic diameter for optimal diastolic augmentation. Now, the volume of the inflated balloon affects the blood displaced. So, factors like tachycardia, aortic compliance, stroke volume can impact the augmentation that comes with the diastolic augmentation. Now, balloon positioning is very important. As you can see in the diagram, it should be 1 to 2 centimeter below the left subclavian artery in the descending aorta. This is the optimal positioning, and this can be documented by radiography, fluoroscopy or echocardiography. These techniques can help us to guide the proper positioning of the balloon pump. And as you can see, we don't want it too below so that it will affect the renal perfusion, or it is too above, thereby blocking the left subclavian artery. Now the material, it is to be mounted on a catheter, allowing pressure monitoring and gas transfer. Helium is commonly used for rapid inflation and deflation and for safety purposes. The insertion site is mostly femoral, but subclavian can also be used. Femoral insertion is easy but has drawbacks, while subclavian insertion allows patient mobility. Upper extremity insertion, that is axillary or brachial artery, or alternative sites, and often using vascular grafts for durability. They have advantages, but the insertion is a challenge especially comparing to femoral and subclavian. Now, upper extremity insertion sites have lower atherosclerosis incidences, allowing for mobilization and long-term therapy. However, in emergency situations where I want the catheter to be in very early, a femoral site is more preferred. This can be done in more stabler patients where I have some time for insertion, and in these patients, it will help in the mobility of them once the catheter is inserted. Now, monitoring and risk of malfunctioning. Now, upper extremity insertion, monitoring for malposition and migration is very, very important. Daily radiograph should be done to monitor the balloon position and its orientation. The next aspect is the console. Now, the console has various components. I will just give a brief overview. Now, the console consists of a gas source, a valve unit, a monitoring system, and a control unit allowing inflation and deflation of the balloon. You get displays of the ECG, the arterial tracing, and controlled augmentation ratios. Now, the triggering and timing of the augmentation is very, very important. The optimal timing relies on the ECG waveform with inflation triggered during the T wave to the P wave interval and deflation during the R wave to T wave interval. Mind you, if there are severe arrhythmias where finding these particular waves becomes very difficult, then you can use the arterial waveform as a trigger for augmentation. Now, this is the normal intra-aortic augmentation. Here, as you can see, the augmentation occurs perfectly on the diacrotic notch, thereby augmenting the diastolic pressure. And in this, the nomenclature is like this. After the inflation has occurred, the subsequent systolic and the diastolic are called the assisted diastolic or the assisted beat, and the previous one is called the unassisted beat. This is of value when there is a 1:2 or 1:3 ratio, but if it is 1:1, this is of not much use. But this gives us a lot of information. That is why we need to understand how the assisted and the unassisted beats differ from each other. The most important differences are, as you can see, the diastolic following the assisted beat is always lower, which means that the afterload has reduced, and you also do find a reduction in the systolic pressure. However, the overall distance increases, thereby increasing the cardiac output as well. So we get a diastolic augmentation, reduction in the afterload, as well as an augmentation in the cardiac output. This is the optimal situation. However, you can have an early inflation. In this, the heart is already beating when your balloon has inflated, which will result in an increase in the afterload and obviously a reduced cardiac output with not much good augmentation. The diastolic augmentation, as you can see, is not that good, and it goes down pretty easily as well. Now, in the late inflation, what happens is the augmentation is not very good because the time has passed, a lot of diastole has gone. After that, my inflation has occurred, and again, my afterload is also affected, and it is not as good as optimal beat. Now, in the early deflation, what happens is again the afterload is not as good reduced as in a optimal situation, and as you can see here, the afterload is slightly higher than the previous afterload, and the augmentation is not very good. And if there is a late deflation, then again your subsequent beat is affected, which means that your so as you can see in the subsequent beat, the systolic is reduced, which means that the inflation was going on even till the next beat. So the next beat, the afterload has increased, so thereby reduced systolic flow. Now next is the timing. Timing assessment should be done in the aortic BP waveform, aiming for enhanced diastolic BP, reduced assisted end diastolic BP, and systolic BP. So these are the 3 points you should look at: the diastolic augmentation, the assisted diastolic, and the assisted systolic. All these should be good, which means that the assisted diastolic and systolic should be lower and the diastolic enhancement should be maximum. Mode of operation. There are 3 modes, that is automatic, semi-automatic, and manual. These decide the trigger, inflation, deflation, and the augmentation ratio. It is always preferred to use the manual mode because these patients tend to be very unstable with lot of variations in their heart rate and heartbeat. So it is very important to see whether the timings and the triggers are optimal. Next is the anticoagulation. Now, anticoagulation is a very important aspect, and currently there are no real standard guidelines how it should be done, and there is no universally accepted uh, protocol which is followed. And the industry guidelines typically do not recommend a routine anticoagulation, especially if the augmentation is set at 1:1 ratio. So in 1:1, basically the balloon is inflating very, very rapidly. So you do not necessarily need an anticoagulation for that. The AHA position regarding this is not very clear, and they have not given any consensus because of insufficient data of how to anticoagulate in these patients. Now, uh, if the IABP is left in a weaning mode, that is 1:3 or 1:4 for extended periods, then a systemic anticoagulation is actually advised to reduce the risk of thrombosis. The benefits of anticoagulation include the decreased risk of clot formation and embolization. The risks involve potential bleeding complications and the possibility of HIT. Now, the criteria for anticoagulation is generally considered reasonable in patients who do not have contraindications to anticoagulation and who are at risk of thrombosis. It is particularly advisable when the counterpulsation is planned for more than a day or the weaning mode is going to continue for more than 30 minutes. Now, caution against a standby mode. IABP should not be set in a standby mode, that is no inflation, unless the removal of the device is imminent. It is likely due to the increased risk of thrombosis formation in the balloon, and it is not actively inflating and deflating. So the anticoagulation is done. The next what we look for is the physiological effects of IABP. How does IABP actually help? Now, as we have already seen, it is the diastolic augmentation, that is the diastolic augmentation of the coronary flow, which is being targeted. And the increase in the coronary perfusion boosts the coronary blood flow unless the coronary autoregulation is impaired. Afterload reduction is done because of the sudden deflation of the balloon. The next is improvement in the cardiac output because of the counterpulsations. Finally, all these things improve the myocardial oxygen supply by increasing the diastolic pressure time index and decreasing the tension time index. These are very, very important terms. The DPTI and the TTI are the important terms that physiologically you should know to show how my IABP is able to improve my coronary perfusion and improve my outcomes by improving the myocardial oxygen delivery. Next, we will come to the contraindications. What are the contraindications and complications associated with the IABP? It is important to thoroughly assess for this before considering IABP as a treatment option. Monitor for and manage potential complication is also very crucial to ensure optimal patient outcomes. Now, contraindications are specific medical conditions or factors that make use of IABP inappropriate or risky for a patient, and complications, on the other hand, are undesirable outcomes of the IABP placement. Now, we will try to see what these are. The first is the vascular injury. The most common complication, 5 to 10% of the cases in the current percutaneous techniques develop vascular complications. Incorrect balloon size, positioning or timing, this can result in limb and organ ischemia, vascular injury, reduced hemodynamic benefits. As I have already shown in the previous diagram, the renal perfusion and the left subclavian can be affected. Balloon malposition, similar as I have already depicted. Catheter occlusion, it may lead to limb ischemia, thrombosis, especially in patients with peripheral vascular diseases. Aortic dissection, fewer than 5% of the cases can happen here. Hemodynamic worsening can happen in aortic valve insufficiencies and dynamic left ventricular outflow obstructions. Infection and bleeding can occur in 2 to 10% of the cases. Balloon rupture and entrapment is extremely rare but a very severe complication which should be kept in mind. Bleeding and thrombosis, along with pseudoaneurysm, aneurysm, dissection, compartment syndrome, limb ischemia, are the major risk factors which should be kept in our mind. And lastly, surgical intervention can be required, like it is 5% of the cases for embolectomy, hematoma evacuation, even amputation and arterial bypass can be done in severe complicated cases. Finally, we see how it has been used over the years. Now, the historical context. Initially, there was promise regarding treating cardiogenic shock with MI with IABP. Now, the clinical trials did not show much benefit, and later studies focused on combining the revascularization strategy like the PTCA and CABG. Now, we will see most of the important trials now. The first one being the Gusto 1, that is 1993. It is a sub-analysis of an RCT. Patients of acute MI and cardiogenic shock, revascularization method was thrombolysis. The findings showed that IABP reduced 30-day to 1-year mortality. The conclusion was in favor. Then the PAM2, 1997, high-risk patients of acute MI, revascularization method was PTCA, finding no difference in outcome with or without IABP. No benefit with IABP. Shock, 1999, RCT sub-analysis, patients of acute MI, cardiogenic shock. The revascularization methods were various, thrombolysis, PTCA and CABG. Finding was lower mortality with IABP, lowest in in-hospital patients with thrombolysis plus IABP. The conclusion favored IABP in MI with cardiogenic shock if thrombolysis is used or an immediate access to revascularization is not available. Next is 2001. This is an observational study, that is MR-MI2 trial. Acute MI with cardiogenic shock, revascularization method being thrombolysis, PTCA, CABG. Higher mortality with IABP and thrombolysis, lower in-hospital mortality with revascularization without IABP. Now, it favored IABP in MI with cardiogenic shock if thrombolysis is used. Now, tactics 2005, it is acute MI with hypotension, revascularization with thrombolysis, no overall benefit of IABP in mortality. Next is the BCIS1, that is 2010 RCT. It is high-risk patient with severe coronary artery disease with ejection fraction less than 30%. PCI was the revascularization method, and IABP had no benefit in this particular patients. CRISP MI 2011, STEMI without cardiogenic shock, revascularization was PCI, no decrease in infarct size or MES at 6 months with IABP. Conclusion, no benefit of routine use of IABP. Next, the most important and the largest trial, that is IABP shock 2012. This was a direct study on this. Acute MI with cardiogenic shock, the revascularization method was PCI. Finding was no change in Apache scores or hemodynamics to IABP. So no benefit of IABP in MI with cardiogenic shock in patients undergoing PCI. Next is IABP 2. This is 2012, multicentric, acute MI, cardiogenic shock, PCI, CABG. No mortality benefits, 2, 6, 12 months. So no benefit with IABP with cardiogenic shock. So across the studies, the use of IABP in the setting of MI, particularly the last few trials, have shown that it has not been of much benefit. So as we have seen, in some subgroups, that is in the patients who have mechanical complications to MI, it has been shown to be of some benefit. Meta-analysis have shown that there is still some difference in the outcome, but overall no impact on mortality has been seen with IABP. Now, the diversity of the study design, patient populations and the interventions associated with it makes the interpretation of the results a little bit difficult. So the current perspective is, despite the lack of clear mortality benefit, IABP continues to be used, particularly in high-risk patients who are undergoing the PTCA therapy. Now, the future research should focus on identifying prospective factors of clinical decompensation to optimize the timing and context of the IABP insertion. Now, the ongoing debate and investigation continues about the precise role of IABP and its efficacy in revascularization techniques. And finally, coming to the guidelines, what the current guidelines are saying. So the backdrop of IABP approval was in 1976, as the medical device amendment required only documentation of substantial equivalence. So no efficacy of proof was required when it was approved for use. Now, since the 1990s, there have been an evolution in the guidelines with more strict requirement of benefits to be shown before using these devices. Now, the current AHA guidelines, that is 2013, shows cardiogenic shock unresponsive to pharmacological therapy for pre-surgical stabilization, IABP can be used. In 2014 NSTEMI guidelines, refractory cardiogenic shock, they are saying it can be used. And in patients with high risk with cardiogenic shock, elective insertion can be done. The European guidelines almost say the same things, and they say that hemodynamic instability due to mechanical complications, consider IABP in select MI patients, especially the patients who have cardiogenic shock or high risk. And despite all these benefits, it is quite popular and it continues to be used very frequently in our practice. Now, the beneficial physiological effects, as we have seen, is the coronary perfusion, afterload reduction, myocardial oxygen demand and supply. Expanding the clinical application to, in the view of the recent uh, ventricular assist devices, should be seen and see how it fits into the management of these patients. So in conclusion, IABP counterpulsation has persisted in clinical use due to its physiological benefits and its relative simplicity and ease of using. Despite evolution in the guidelines and evidence, it has definitively some positive roles. Considering the strong physiological basis, we need to find the population and the risk factors which actually will give us better outcomes. So we need better studies. Until then, we continue to use them in select group of patients, especially high risk patients with cardiogenic shock with mechanical complication of MI. Thank you for your patience.